Imagine going to the doctor with a severe, painful structural breakdown of your most delicate skin, right? And the doctor just hands you a tube of teenage acne cream.
Yeah, I mean, it sounds like a mistake. It sounds totally bizarre.
It really does. But today, we're actually unpacking a medical paradox. We are looking at a diagnostic and therapeutic landscape that forces doctors to get, well, incredibly creative.
Right, because modern medicine sometimes really requires just throwing out the standard playbook entirely.
Exactly. And we've customized this deep dive just for you, knowing you're the kind of listener who wants to understand not just what doctors prescribe, but like the underlying biological mechanics. You want to know why a completely unexpected treatment might be the literal only thing that works.
And the condition we are looking at today, which perfectly illustrates this, is called lichen sclerosus, or LS.
Right. And for anyone maybe just catching up on this specific field, let's establish our baseline really quick. Lichen sclerosus is a chronic inflammatory skin condition. It typically presents as these thin, white, wrinkled-looking patches of skin that are just intensely, maddeningly itchy. And it most commonly shows up in the anogenital region, though I know it can appear on other parts of the body too.
Yeah, it absolutely can. And because we are dealing with this local, highly overactive immune response causing massive inflammation in that area, the absolute gold standard for treatment is a super potent topical steroid.
Something like clobetasol propionate, right?
Exactly. You apply the steroid, it suppresses that local immune response, the inflammation goes down, and ideally, the patient enters remission.
But there is always a scenario where the gold standard fails. Like a patient uses that ultra-potent steroid and their tissue just totally ignores it. The inflammation just rages on.
It happens more often than you'd think, unfortunately.
Yay. So our mission today is to explore the therapeutic role of topical retinoids in treating lichen sclerosus as that crucial backup plan. Okay, let's unpack this, because when you hear the word retinoid, you are likely not thinking about complex autoimmune diseases.
Definitely not. You're likely picturing, a fancy nighttime skincare routine.
Right, like expensive anti-aging serums promising to erase fine lines, or maybe strong face washes designed to clear up cystic acne.
Yeah, exactly. We're talking about derivatives of vitamin A, specifically things like topical tretinoin, usually formulated around 0.025%, or tazarotene at 0.01%.
So bringing a vitamin A acne derivative to a severe inflammatory genital skin condition sounds completely counterintuitive.
It does. It sounds like you're grabbing the wrong tool from the toolbox.
Yeah. To understand why a dermatologist would actually make that leap, I guess we have to strip away the marketing of retinoids and really look at the cellular battlefield of LS.
What's fascinating here is that lichen sclerosus isn't just some surface-level rash that you can soothe with a basic lotion. It's much deeper.
Right.
The local immune response in the lower layers of the skin sets off this chaotic chain reaction. And that reaction physically alters the entire architecture of the tissue.
So the structural scaffolding of the skin is basically degenerating. You get all the scaling, extreme dryness, and just abnormal cell growth.
Exactly. And the microscopic construction workers that are responsible for building and maintaining that skin scaffolding, they're called fibroblasts.
Okay, fibroblasts. So on a normal day, what are they doing?
On a normal day, those fibroblasts are just diligently laying down collagen. They keep the connective tissue structurally sound, elastic, healthy.
Right.
But in lichen sclerosus, the immune system essentially hijacks those construction workers. It sends them these chaotic, inflammatory signals, forcing them to build weird, thickened, unhealthy tissue instead.
Oh, wow. So they're just getting the wrong blueprints. And this is where the retinoids enter the picture, right? Because they aren't just exfoliating the dead skin off the surface.
No, not at all. They are penetrating way down into the tissue and communicating directly with those hijacked cells.
So think of a fibroblast, like a factory machine that has a physical keyhole on its surface. The retinoid molecule is a highly specific key that just floats down, slides into that receptor keyhole, and physically turns off the switch for that abnormal production.
That is a perfect way to describe it. That physical interaction at the receptor level is absolutely crucial.
So it's a mechanical override.
Yeah, exactly.
Yeah.
By sliding into that keyhole, the retinoids actively downregulate the fibroblast function. They're overriding the immune system's chaotic instructions.
So the retinoid literally tells the fibroblast to stop the runaway connective tissue degeneration.
Right, it forces it to stop.
So instead of being this, magic fountain of youth, the retinoid in this context acts more like a microscopic traffic cop, just halting the production of that unhealthy tissue.
Yes. And clinical studies, along with observational series, they really back this up. They show that this cellular override can actively reduce the scaling, reduce the extreme dryness, and actually improve the gross appearance of the skin.
And even under a microscope, right, like the histopathologic features improve.
Exactly. Bypassing the inflammation to go straight to the cellular machinery is just a brilliant biological hack.
It is, but I mean, we have to address the reality of actually applying this chemical messenger to the human body because retinoids are notoriously aggressive.
Oh, very aggressive. As anyone who has used a strong retinoid on their face can attest, they cause significant redness, peeling, burning, and stinging.
Wait, hold on. We are talking about applying this to anogenital skin. That tissue is already naturally delicate, right?
Highly delicate.
And in a patient with LS, the skin barrier is already severely compromised. Like, it might be severely thinned out, fissured, or literally cracked open.
Yes, the barrier is essentially destroyed in those areas.
So if applying this cream feels like putting hot sauce on a sunburn, I mean, how do patients actually stick with the treatment? Putting a harsh chemical cream on damaged genital skin sounds like absolute agony.
It sounds like absolute torture, quite frankly. And if you applied it like a standard lotion, it would be.
Okay, so you don't just rub it on and leave it.
Definitely not. If a patient simply smeared tazarotene onto an active denuded LS flare and just left it there to absorb all day, the pain would be totally excruciating.
God, I can't even imagine. And that would probably just cause more inflammation, right?
Exactly. It would likely trigger a massive inflammatory response, which completely defeats the purpose of the treatment.
So dermatologists must have some kind of workaround, some way to get the key into the keyhole without burning the factory down.
They do. They rely on a highly pragmatic, off-label protocol called short contact therapy.
Short contact, meaning you are basically washing it off before the burning really sets in.
That's exactly it. The goal is to give the skin just enough exposure to let that vitamin A derivative sink in and bind to those fibroblast receptors, but you remove the vehicle before it triggers massive surface irritation.
So how short is short?
The patient applies the retinoid gel or cream directly to the affected genital lesions, but they only leave it on for 15 minutes.
Wait, just 15 minutes?
Just a very brief, strictly controlled 15-minute window. And then they thoroughly wash it completely off the skin.
Wow. Okay, so you are basically threading the needle between efficacy and agonizing side effects. But is 15 minutes really enough time for the retinoids to penetrate the tissue and actually halt that connective tissue degeneration?
It is enough to initiate the signal, yes, but it's not a one-and-done thing. This requires a progressive training process for the tissue.
Training the skin.
Yeah, the skin has to build a tolerance to the chemical messenger.
Mm.
So after doing this 15-minute protocol for about 2 to 3 weeks, the patient incrementally increases the application time by another 15 minutes.
Oh, I see. So pushing it to 30 minutes.
Right, pushing it to 30 minutes, assuming their skin can actually handle it.
And then what, 45 minutes a few weeks later? Slowly increasing the exposure until they hit the therapeutic effect they need?
Exactly, or until the adverse burning effects just become too limiting. It really is incredible clinical ingenuity, just training damaged tissue to accept a harsh but necessary medication over time.
That's wild. Now, we should note that lichen sclerosus isn't strictly confined to the genital region, right? I know it can also appear on the trunk, the breasts, or the limbs.
Right, which we refer to clinically as extragenital LS.
Extragenital. Okay, so the skin on your back or your arm is obviously significantly tougher and thicker than anogenital skin. Does the short contact rule still apply there?
Generally, no. For extragenital LS, the skin's barrier function is robust enough that short contact therapy usually isn't necessary.
Oh, so you can just leave it on.
Yeah, the retinoid can usually be applied and left in place. And sometimes it's even layered in conjunction with a topical steroid to tackle both the inflammation and the cellular structural breakdown simultaneously.
Okay, so we've established that this cream is an incredibly harsh, incredibly specific tool, and the application requires this tedious, heavily monitored protocol. I mean, a doctor wouldn't subject a patient to that unless the skin itself had become some kind of fortress that standard steroid ointments just couldn't penetrate.
Precisely. It is definitely not a first-line treatment.
Which brings us to when doctors actually pull the trigger on this prescription.
Retinoids are strictly reserved for steroid-resistant cases. If clobetasol is effectively managing the disease, you stay with clobetasol.
Right.
Always.
Don't fix what isn't broken.
Exactly. But retinoids become the necessary weapon for a very specific presentation of LS known as hyperkeratotic or hypertrophic lesions.
Hyperkeratotic meaning heavily thickened and scaly, right?
Yes. In a subset of patients, the tissue degeneration doesn't manifest as that thin, fragile, paper-like skin we usually see. Instead, the skin reacts to the local immune attack by hyperproducing keratin, which is a structural protein.
Ah, okay. So you end up with these thick, stubborn, leathery plaques.
Exactly. The hyperproduction of keratin is essentially the skin trying to build a defensive wall against the inflammation.
But that wall becomes so thick that a standard steroid ointment physically cannot absorb deep enough into the tissue to calm the underlying immune response.
That's the exact problem, which means the inflammation just continues unchecked beneath this leathery plaque. And if those hypertrophic lesions fail to respond to ultrapotent steroids, that is the moment the dermatologist introduces the retinoids.
Here's where it gets really interesting to me. Because we are looking at this wild chemical balancing act. Like, we know one of the long-term side effects of strong topical steroids is that they thin the skin, right? They cause atrophy.
Right, that's a well-known side effect.
But in this specific hyperkeratotic presentation, the patient's skin is far too thick. So the doctor is actively deploying a retinoid specifically to break down and thin out that overly thickened fortress. You're essentially using a chemical's usual side effect as the primary therapeutic benefit.
Yes. It perfectly highlights how precision medicine operates in chronic conditions. You aren't just treating a generic label of lichen sclerosus.
You're treating the exact presentation in front of you.
Exactly. The treatment must perfectly match the specific physical presentation of the tissue in that exact moment. You use the retinoid to dismantle the hyperkeratotic wall so that normal structural function can resume.
But what happens when the fortress is too strong, even for the short contact topical therapy? Like, if the creams and gels just totally fail, are there systemic options?
There are. For severe refractory disease cases that just relentlessly progress despite topical steroids and topical retinoids, there is a role for systemic retinoids.
Okay, systemic. Meaning moving away from localized creams and taking the vitamin A derivative orally in pill form.
Right. Delivering those chemical keys straight through the bloodstream.
Wow. What does that look like?
Well, doctors will prescribe drugs like acitretin, usually at a dose of about 20 to 30 milligrams per day, or sometimes isotretinoin. And small clinical trials have shown that oral acitretin can be effective over a 16-week period for these really severe cases.
Because by putting the medication into the systemic circulation, it's attacking the problem from the inside out.
Exactly. The systemic retinoids work by actively decreasing the size of the sebaceous glands and systemically inhibiting that abnormal keratinization we were just talking about.
So it forces the whole body to stop overproducing that leathery structural protein.
Yes, it hits the brakes system-wide.
But taking a systemic retinoid is a massive physiological event. We really need to talk about the baggage that comes with this class of drugs.
Oh, absolutely.
Because if you swallow a pill, those chemical keys aren't just traveling to the LS lesions down there. They are circulating through your entire body, sliding into cellular keyholes everywhere.
The systemic baggage is extremely heavy and requires intense medical supervision. You are fundamentally altering cellular turnover across every organ system in the body.
Wow. So what are the common side effects then?
Well, common side effects include severe cheilitis, which means the patient's lips become incredibly inflamed and cracked because the drug aggressively dries out the mucous membranes.
Okay, so painful cracked lips.
Yeah. They also experience extreme xerosis, which is profound, total body skin dryness.
Oh man, so you're basically trading a terrible localized itch for full body cracked skin.
Often, yes. And we're also looking at elevated liver enzymes and hypertriglyceridemia, meaning huge spikes in blood fats.
Why does it affect the liver and blood fats so much?
Because the liver has to heavily metabolize these systemic retinoids, which naturally strains liver function and alters lipid metabolism. Hence those huge spikes in triglycerides. Patients can also suffer from abdominal pain and, very frequently, alopecia, hair loss.
Wait, why does a derivative of vitamin A cause your hair to fall out?
Because systemic retinoids fundamentally alter cell turnover, as we mentioned. Hair follicles naturally have a very rapid cell cycle.
Oh, I see.
So when you flood the body with a drug designed to suppress overactive cell growth, it accidentally signals those fast-growing hair follicles to shut down prematurely. The follicles enter a resting phase, which leads to widespread hair shedding.
That is brutal. Dealing with cracked lips, liver strain, and hair loss is a massive physical toll. But that isn't even the most critical danger associated with systemic retinoids, is it?
Not even close. The absolute most severe risk with retinoids is profound teratogenicity.
Teratogenicity, meaning they cause severe birth defects.
Yes, they are classified as a Category X drug, meaning they are absolutely unequivocally contraindicated during pregnancy.
Because they disrupt the cells so much.
Exactly. Because retinoids so powerfully influence cellular signaling and structural development, introduce them to a developing fetus disrupts early embryonic cellular instructions, and that leads to catastrophic physical and cognitive defects.
So what does this all mean for a younger patient? Like, if we connect this to the bigger picture of medical treatment, this completely rewrites the rule book for prescribing this to a female patient of childbearing age, doesn't it?
If we connect this to the bigger picture, it absolutely does. If a female patient is taking a systemic retinoid like acitretin, avoiding pregnancy during the course of the medication is just the beginning.
Just the beginning.
Yes, she must strictly avoid pregnancy for at least 2 years after she takes her final pill.
Wait, a 2-year waiting period after the medication is completely stopped? Why does the danger linger for that long?
Because retinoids are highly lipophilic, meaning they dissolve in fat.
Okay.
So rather than being quickly flushed out through the kidneys like water-soluble of drugs, retinoids are absorbed and heavily stored in the body's fat cells.
Oh, wow. So they just kind of hang out there.
Exactly.
Yeah.
It takes an incredibly long time for the fat cells to slowly release the drug back into the bloodstream to be eliminated. It takes 2 full years to guarantee that the teratogenic chemical is entirely cleared from the system.
Think about what that actually means for your life planning. If you're a 28-year-old listening to this and hoping to start a family before 30, taking this pill completely rewrites your timeline. A 2-year ban on pregnancy just to treat a skin condition is a massive, massive lifestyle impact.
It takes the option completely off the table for many young patients. And this intense biological lingering is exactly why clinical guidelines strictly require a referral to a specialist dermatologist before even considering initiating systemic retinoid therapy.
Because the risk-reward calculation here is just astronomical.
It is. The physician and the patient have to sit down and have a very serious conversation. Is the severity of the lichen sclerosus, the potential for permanent scarring, for losing the structural architecture of the body, is that worse than the systemic risks, the liver strain, and a 2-year pregnancy ban?
And I imagine for some patients the answer is actually yes.
For some patients suffering from crippling, steroid-resistant LS that is just destroying their quality of life, the answer is yes. The retinoid is the only key that fits the lock to stop the disease. But it is never a decision made lightly, and it requires constant blood work and monitoring.
It really paints a vivid picture of just how complex managing a chronic autoimmune condition can be. The medical field is constantly weighing the damage of the disease against the collateral damage of the cure.
Absolutely.
So to bring this all together for you listening, even if you don't have lichen sclerosus, you now possess a pretty fascinating understanding of off-label drug repurposing.
It's quite a journey.
Yeah, I mean, we've taken a chemical famous for clearing up teenage acne and fighting wrinkles and figured out how to use it to biologically hack the connective tissue of a chronic autoimmune disease. The retinoids slide into those fibroblast keyholes and just shut down the runaway tissue breakdown.
Exactly right.
And when that topical chemical proves to be too harsh, burning the already damaged skin, clinical ingenuity steps in. Doctors figured out how to outsmart the intense side effects using short contact therapy, training the cells with brief 15-minute bursts of exposure to get the message across without causing a localized fire.
It is a phenomenal encapsulation of how modern dermatology actually works.
Yeah.
You have to understand the underlying why of a treatment to effectively utilize it.
The mechanics of it.
Right. Why does the skin thicken into a fortress? Why does vitamin A stop that hyperkeratosis? And why does it stay in the body's fat cells for 2 whole years? When you understand those intricate cellular mechanisms, you can adapt the delivery and manage the risks.
Yeah.
I always encourage people to question the biological why behind any therapy they're prescribed, because understanding the mechanism empowers you as a patient.
The more you know about the why, the less mysterious and terrifying the whole medical process becomes. And as we wrap up this deep dive, I want to leave you with one final kind of provocative thought to mull over.
Okay.
We know that the specific chemical signal from the retinoid is exactly what those overactive fibroblasts need to hear to stop destroying the skin in LS. But right now, that vital signal is attached to a vitamin A derivative, which brings all that heavy systemic baggage. The severe mucous membrane drying, the rapid hair loss, the lipophilic fat storage, and those catastrophic pregnancy risks.
All of it.
So, could the future of lichen sclerosus treatment lie in isolating that exact chemical signal and delivering it to the fibroblast receptors without using vitamin A as the vehicle at all?
Oh, that's the dream.
Right. Imagine a world where pharmaceutical engineers could just send the specific key to shut down the factory machine without bringing the burning and the toxicity along with it, just eliminating the skin burning and the pregnancy risks entirely.
Finding a way to decouple that cellular override signal from the teratogenic toxicity of vitamin A is essentially the multi-million-dollar question for pharmacological researchers studying connective tissue diseases right now.
It's definitely something to think about the next time you see a tube of anti-aging retinoid cream at the pharmacy, right? There is a whole microscopic battleground happening right beneath the surface. Thank you so much for joining us as we explored the science and the strategy behind this fascinating topic. We'll catch you on the next deep dive.